Hello. This video is designed to try to help third-year medical students write really outstanding history and physical write-ups during their internal medicine clerkship. What I'm going to do today is go through a new template that I've developed and I hope will really help guide you to write a really outstanding write-up, and also to talk about the structure of your assessment and plan so that you can really demonstrate your clinical reasoning. The write-up itself is, of course, part of it is to demonstrate your clinical reasoning for grading purposes, but it's also a really specific structure, and the hope is that by using the structure over and over, you will grow as a physician and grow as a clinician, and that the structure itself will really push you to read and to learn and to get as much out of this writing and learning experience as possible. So I'd just like to start by going through the actual grading worksheet, because I think a lot of students don't really look at this fully, and when I'm grading I can often see that there are some holes in what the expectations are. So certainly for the history of present illness, the HPI, please be aware that we're really looking for you to describe the complaint in those typical location, quality, severity, duration, timing, radiation, and aggravating and alleviating symptoms, that standard structure, as well as using descriptive vocabulary like acute, chronic, sharp, dull, continuous, intermittent. I can say that when I'm grading these, I actually keep a list of these 7 things and check them off as I see them demonstrated in the HPI. Obviously, we want it to flow logically, put it into a context, put the HPI into context of what other medical problems the patient has, as well as be really complete in the patient's past medical, surgical, family, social histories, as well as review of systems. So what I've tried to do in this new template is to give you prompts so that you're remember to really follow this rubric and do as well as possible, while at the same time trying to take out as much as the auto-populating components of the old template, and really just set the students up for success here. So just to start at the very top, to walk you through this template and what some a good example of using it would be. I first want to just say that when I'm reading a lot of these HPIs, what can be really tricky is that I don't know when the patient was admitted and if the patient's onset of symptoms are given in terms of date. So on January 1st, the patient developed shortness of breath. If I don't know what date the patient was admitted, it can be really hard to put that information into context. So I've added this date of admission component right here. Having said that, it's much easier to read for all readers, I think, regardless of whether this is a graded HMP or if it's just looking at HMPs in EPIC from past admissions. I think it's the easiest to think of things in terms of days prior to admission, hours prior to admission. Use that in terms of framing your time course. The chief complaint should be in the patient's own words, what they said they came in with. And then it's also often helpful, as you know, to know who the history was obtained from. And it's a good habit to get in if you're using interpreters to document that at that point in time. All right, so what I have here in italics, and the way that I tried to structure this template is that anything in italics is a prompt for you, probably should be erased, but giving you structure so that the quality of your work is as high as possible. So certainly to start with the summary statement, and then the things that are in the grading rubric I've included here. So an example would be, this is a sample write-up I did. So the summary statement, 45-year-old woman, history of obesity, status post-Roux-en-Y gastric bypass surgery 1 year ago, impaired glucose tolerance and asthma, controlled on an albuterol meter dose inhaler, presenting with shortness of breath. So I specifically chose a chief complaint that didn't involve pain. If a patient is coming in with pain, it really should be pretty straightforward to include all of these qualifiers here. But if for things like, I think, shortness of breath or complaints like that are standard to congestive heart failure, it may be harder to go through that litany right there. So this patient, I mean, you can read the the paragraph here that describes the time course and the symptoms and how they presented, and note that I think the reader is, hopefully you, the reader, is able to get a very clear picture of what this patient looked like coming in. And I hope what you're getting from this is that you can really see what she looks like and have a good sense of what the events that were leading up to her presentation. So I'll just give you a second to read that through. Now, a key thing is after the time course, I have a paragraph here that looks that examines some of the triggers that your reader is probably thinking about, and a specific review of systems to the chief complaint. So it's very tailored to the chief complaint. And as a reader, you're probably thinking of a lot of things that, is this asthma, is this something else? Hopefully the information that's included in these paragraphs are addressing those thoughts and concerns that you might have. Then there's this paragraph here that specifically looks at the asthma history, okay? So I don't want to read everything, so just take a look at that. You see that it's very specific to the chief complaint and the history that relates to that. Okay, and then a paragraph about what specifically happened in the emergency room. If you need to pause to read any of these parts over, please do. Now, immediately after the HPI, we have this review of systems, and this is a very long review of systems. I personally believe that if it's included in this review of systems, even if it isn't positive, you need to have asked the patient. You should not have any information in there that you did not specify with the patient. So if you don't ask about perhaps easy bruising, I would just erase that. I wouldn't include it. I think this is very extensive. When you are more senior and an attending, you are required for billing purposes to have a 10-point review of systems. So you need 10 organ systems there. But if there's something that isn't relevant to the patient's chief complaint, then I believe you can take that organ system out as long as you have 10 things there. Okay. But make sure that everything is asked about. And if you haven't asked about it, you have your 10 organ systems and it isn't relevant to the chief complaint, it's okay to take it out, to erase it. Now, I just want to show in terms of the past medical history and past surgical history here. So what I don't want is auto-populating from Epic. I think Epic is a great resource to get a sense of what a patient's history is, but everything that you include in your note should be clarified with the patient. So asthma, I think that probably the HPI had plenty in terms of describing exactly the time course, and I think if you write per above, that's adequate. Now in this patient's case, there's details about her history of type 2 diabetes and impaired glucose tolerance. You can go ahead and read it there. The kind of information your reader wants is to know how bad it is. So in this case, her hemoglobin A1C is a good indicator. What medications you're on. I mean, I know that I'm able to very quickly determine how severe someone's diabetes or heart failure is by simply evaluating the medications that they're on. And then if there's any other relevant information, in this case, this patient's surgical history is pretty impressive, that can be mentioned. Just be careful not to be too repetitive here. You can certainly use Epic to look at what the past medical history is, but I wouldn't use the auto-populating function because it just doesn't give your reader enough information, and a lot of it is often incorrect or wrong. Same thing with the social history. I would encourage you to put this in yourself and make sure that whatever you include here, you have clarified or asked the patient about. Okay. Now, medications prior to admission. This is an area where If the medication reconciliation is accurate, then by all means, I think you can use it. For just so you know what the dot phrase here is .pta medication list. Okay. Having said that, if you're going to use the auto population function, you must make sure that everything that's being used is appropriate. Okay, so that's what it is there. Allergies, again, as long as you clarify with the patient that the allergies that are in the system are correct, you can certainly use auto population, but it needs to be verified. I don't want it to just be an automated thing. Okay, with your physical exam, your vital signs, I mean, that's again, I wouldn't necessarily type in those things independently. You can use vitals within the last as my personal favorite vital sign auto population. In terms of, I've included this template for the physical exam that is pretty standard, but I really want to emphasize that if you are including this, you have done it. If you have not evaluated the range of motion in the patient's back, it should not be there. If you have not done an exam for costovertebral tenderness, it should not be included. Okay, so if it may not be relevant to the patient's HPI or chief complaint to do some of these exams, more detailed exam findings, but if you haven't done it, then it needs to come out. And if you have done things that, if this was a heart failure patient and you examine their JVD and did additional exams that aren't included on here, please add that in. Make it as accurate and comprehensive as you feel appropriate. Now, the data section is something else that I've modified here. What was there before was something that was auto-populating, and it was clear to me that students weren't taking out what wasn't relevant or very outdated. You have these like CRPs from 2 years ago. For labs on admission, you don't have to write in everyone manually. I'm a fan of last 24-hour results, which will give you everything that has resulted in the last 24 hours in terms of lab data. It will also include EKGs, which I manually take out. We'll talk about that in a second. But usually whatever has happened in the last 24 hours is relevant to the patient's chief complaint, so certainly should be included. If a patient has had an EKG on admission, and almost all of them have, you should interpret it yourself. Same thing with a chest x-ray. If patients had a chest x-ray on admission, you should interpret it yourself and put that interpretation in. Prior lab data. This is really key here, is if you're trending any labs, like patients coming in with a new creatinine elevation and you're saying that the patient has acute kidney injury, it's really helpful to know what their baseline is, and so including data from the past so that your reader can get a better sense of exactly what's new, changed, and worrisome is really helpful. You don't necessarily have to manually write everything in. There are dot phrases, like if you want to trend the creatinine, there's a dot phrase that's last creatinine 3 right there, that will give you the last 3 readings. You may need more information than that. You may have to trend it back much further, but it at least gives you something to work with. It's good for you to begin to know about various dot phrases that can help with this. Please do include prior relevant imaging. You can, for those, I'm happy for you to copy and paste prior CAT scans, echo reports, cath reports, and I guess that gets into the prior relevant cardiac workup. Not every patient is necessarily going to have cardiac workup that's relevant, but I do include that heading as certainly for any cardiac patients, you want to be as inclusive as possible with what prior workup they've had. Okay, so that gets then to the assessment and plan. I've put in this structure here just because what I could see is that there were a lot of students that had a lot of very good thoughts and really, I think, had thought about a pretty extensive differential, but many weren't, I guess, arguing it with the structure that would make their arguments look as good as possible. Many students were already doing this, and then others weren't. So I thought I'd at least give you the structure here so you can put that information into place. Definitely start with a summary statement. Sorry, there we go. An interpretive summary. One of the, I think, many students write a very good, I guess, summary of the chief complaint, the key physical exam findings, and the key lab abnormalities that are concerning. I would encourage you, if you feel that you're able to or you have a very strong feeling of what ultimately is going on from the diagnosis perspective, you can add a sentence at the end that the leading diagnosis on the differential at this point in time is an asthma exacerbation. I think beginning to start that process of synthesis and interpretation is a good one. So I often tell you, so problem number one, that be very careful that you use a problem utmost. Many students will say that this will put their problem number one as the actual diagnosis, so congestive heart failure or asthma exacerbation. And I would encourage you to take a step back and say, what's the actual problem here, not necessarily the diagnosis. So in the case of the patient's HPI that I was giving you, the problem, and it can be kind of a cluster of problems: shortness of breath, wheezing, and hypoxia responsive to nasal cannula oxygenation. So differential for that includes, and I encourage you to come up with 3 to 5 things on your differential. And general teaching point and all that wheezes isn't asthma. So I laid out a differential here: asthma exacerbation, CHF exacerbation, pulmonary embolism, COPD, and then something that's a little bit more unusual, but Churg-Strauss. So back to the structure. So differential number one, I think at least starting with a kind of bullet point approach is a good one. So that would be asthma exacerbation here. Now, I think it's a good idea to think about the things that are supporting and refuting. In this case, the story is such a strong one for an asthma exacerbation that you can certainly use the typical presentations. Like, this is pretty simple, but asthma commonly presents after a viral respiratory tract infection. The patient has a history of asthma, has sustained some relief from standard treatment. While the patient was exposed to various triggers, it's not necessarily an obvious, or the time course isn't exactly consistent. What we are looking for, going back to the grading sheet, is for things to be really well explained, and of course looking down at the bottom where the real grading happens here. We want a complete pertinent differential that commits the most likely diagnosis, but accurately defines the epidemiology and key features. So that's where I would push you as a little bit further to think about the key evidence and the key evidence and pretest probability, things like that, when you're thinking through exactly what's going on. Now, I think that's where a lot of students struggle, is where to find that seminal literature. And I want to talk a little bit about how to find the information that's going to make your arguments the strongest. So I do read H&Ps where I can tell that students really wanted to go to the seminal literature, and I don't know exactly what they did, but it seems like they may have gone to like PubMed and just typed in kind of a random point, found an article, and gone from there. And I think it's stronger if you go to the literature that is the basis of recommendations and standard of practice. That can be hard to find out, especially when you're in the beginning as a student. You haven't gone to all of the morning reports and noon conferences that your house staff and residents have. What I encourage is that you start by going to the standard texts that you're using every day. So I'm sure many of you are using Pocket Medicine, the Washington Manual, Up to Date, these kinds of things. So what I pulled up here is this is the Pocket Medicine pages for asthma. And you'll see that they're quoting the New England Journal article here. They're quoting Lancet article, as well as what's called, let's see, over here they're talking about, the severity of asthma. There's the GINA, there was actually just an update in 2019. So I would look through, for something like this, looking through what Pocket Medicine is quoting, what the Washington Manual is quoting. I would go through the up-to-date articles and look at the articles that are being quoted there, to look at really where a lot of the foundation of both the diagnosis as well as management is coming from. And I would do that for every single one of the things on your differential, because this is a good starting point, and it will point you towards the citations that are probably going to be the most strong, meaningful, and will point you in the right direction in terms of practice management. You will get so much out of learning this way. I really think this is something that this practice has taught me more when I think about my medical education than anything else, is thinking through differentials, reading the seminal articles in the context of trying to figure out exactly what's going on with the patient. So for the asthma component of this patient's presentation, I did just to show you what I did is in terms of the principles of treatment, I went to this citation right here for treating an asthma exacerbation. And sure enough, this article in New England Journal goes through the practice management here, which is exactly what I would envision for this patient, as well as really great explanation with further citations of why we use the medications that we use for treating an asthma exacerbation up front and what to do next. So again, your learning and reading this article is fantastic, but then you're able to detail in your actual write-up why you're going to do what you're going to do. And I will say that is the most common place where students get points taken off. Like going through the plan, many students do what their interns do, which is just list the plan. So nebulized albuterol, Q4 hours, space out to Q6 hours as patient can tolerate. And you'll see here that decision-making skills, one of the points, if listing the diagnostic testing and treatment plan will only get you 1 point. What you need is to use evidence to support the most important diagnostic testing and treatment plans. So let's take a step back. Let's go back to the structure that I was outlining. So you want, as I said, you want to make sure you have your number one your problem, include a differential. With each differential, lay out the reasons that support that differential as what's going on with the patient, as well as the things that might be refuting it as the primary cause. You want to do that for each one, and for each one of these the things on your differential, you should look up in the seminal articles, the seminal guidelines in terms of diagnosis for each one of those things, and as relevant, include that. Then you want your statement that says what you think is most likely going on and why. And at that point, you may want to give more details on that. For instance, in the case of this asthma exacerbation, you may say, I think that it's most likely this patient is having a severe asthma exacerbation for these reasons per this criteria, for the GINA 2019 criteria. And then you can go into that for more detail. And then from there, you want to go through your plan. And that's where the data, you do want to include citations and evidence with regards to why you're proposing what you're doing. And that shouldn't just be a list, it should be more of a discussion. Okay? Then it's I put a problem number 2 on the list with the same process. And what I often will see is that students put in a tremendous amount of energy into what the primary thing that's going on, and that is wonderful. But then there will be other smaller problems that they will, like for instance, a patient will also be anemic. And while the anemia may be something that's part of the primary problem that the student has stated, it too also deserves at least some discussion and in terms of its differential and what's most likely going on. Finally, I'd like you to think about the social determinants of health that are impacting the patient's care. As we've talked about in many different venues, the social determinants of a patient's health often have more impact in their larger care than anything that we can really do in the hospital. And it behooves you to start to think about what the barriers to discharge, what the patient's life in the outpatient world, who their support system is, those sorts of things. It certainly makes the most sense to start thinking about that at admission, and to get that process going, which is why we've added this line here to help you become the best doctors you can be. So hopefully this is not just a practice of getting better at documenting your clinical reasoning skills, but my hope is that by thinking through the broader differentials and using this more structured, bulleted format, that you'll be able to get more out of this whole process, to be able to learn more, to really go back to these seminal articles and guidelines that shape what we do and get the most out of this process. I will say that this takes a lot of time, that these write-ups are a big investment of energy. I'm hoping it's worthwhile. I would also say that sometimes it's maybe worth starting when you're writing with the assessment and plan component, to really think about how you're essentially making your argument for your reader as to what you think is going on, what you think is the most likely thing on the differential. I'll also say that I know when I was a student, sometimes as I started to go through pocket medicine, you know, in the terms of an asthma exacerbation, learned that, you know, I should have probably asked about what the triggers were, and I didn't ask a patient if they'd been, you know, taking extra NSAIDs or been exposed to secondhand smoke. You can always go back to your patient and round out your HPI with as much information as you get in this process. So please make these write-ups as complete as possible. It doesn't, you know, you can certainly be reviewed by your attending and your resident, get further feedback. One thing I would mention though, make sure with the one that you're turning in is a finalized form and doesn't have a lot of, I've gotten the marked up versions on a few occasions. So anyway, I hope this is helpful and can't wait to read what you plan on submitting. Thanks.